All right, everyone. I want to welcome you to today's webinar. This is Michael Bray at the Developmental Disabilities Institute down at Wayne State in Detroit. I want to thank everybody who signed up to participate today. Just a couple housekeeping things before I introduce Rachel. We will be taking questions throughout. If you look to the right of your screen, at the bottom of your GoToWebinar control panel, you should have a place to type in, either be called a chat box or a question box. You can type your questions there. Rachel's going to pause throughout her presentation to address your questions. So whenever you have a question, please feel free to enter it there, and we will be addressing those. You also can control the volume on your own computer with your own volume controls to adjust for loudness, or if you'd like it quieter. Or if you'd rather, you can dial in to the presentation as well. You should have the dial-in information on your screen right now on the title screen. And you do have an audio pin that you will have to enter on your phone if you prefer to listen that way. So today's webinar is entitled The Affordable Care Act, What's Changing, What's Not for People with Disabilities and Direct Support Professionals in Michigan. Rachel Patterson is the Policy Analyst for the Association of University Centers on Disabilities, where she focuses primarily on health and long-term services and supports policy. Rachel leads AUCD's Health Reform Implementation Workgroup, co-chairs the Consortium for Citizens with Disabilities Task Force on Long-Term Services and Supports, and represents AUCD and national coalitions working to advance health and LTSS policy. Prior to joining AUCD, she was a research assistant at the Burton Blatt Institute in Syracuse, New York. She has an NPA from the Maxwell School of Citizenship and Public Affairs at Syracuse University, and a BA in politics from Whitman College in Walla Walla, Washington. Her sister Amy has intellectual and developmental disabilities and lives in the Seattle area. So let me pass the baton here to Rachel, and we can get started.
All right. Thanks, Michael.
You're welcome.
Yeah, like he said, I'm Rachel Patterson from the Association of University Centers on Disabilities. We're the membership association of organizations like DDI at Wayne State that are university-based disability centers. And today I'm going to talk about the Affordable Care Act. Like I said, what's changing, what's not, for people with disabilities and direct support professionals, specifically in Michigan. So I'm going to provide an overview of the law, the Patient Protection and Affordable Care Act. In case there is any confusion out there, some people call this Obamacare, some people call it the Affordable Care Act. I call it the Affordable Care Act because that's the actual name of the law. But in case there's any confusion, they're the same thing. And so today I'm going to talk about three main areas. The coverage expansion, so expansion of health coverage, reforms to the health insurance system, and then reforms to the health system overall, how healthcare is delivered. And after each of those sections, I'll pause for questions because I think it can get kind of confusing, and I hope to allow for as much interaction as possible. So I like to start with this slide talking about why we were talking about health reform and why we passed the Affordable Care Act in the first place. And this shows healthcare spending as a share of the economy from 1960 and then projected all the way to 2020. And the reason that this is one of the reasons that the country was talking about health reform was that care expenditures, health care expenditures, so that's everything we spend on doctors and hospitals and nurses and prescriptions and all of those health things, the cost of it was going through the roof. A lot of that has to do with demographics. We were a growing population, we're an aging population, and so we're using a lot more healthcare, and the cost of each individual healthcare service was also increasing. The cost of knee replacement surgery this year costs more than it did last year, partially because it's better, but also because of all sorts of economic factors that cause those costs to rise. This means, and even though we're spending all of this money, we still had a lot of people who didn't even have health coverage. So this graph shows people without health coverage prior to the major coverage expansions of the Affordable Care Act coming into effect. So the ACA was passed in 2010, so we've got 2007 through 2011 showing all these people without health insurance. And, not surprising, people without health insurance tend to not access health care. So this shows that people who don't have a place that they usually seek care, a place sometimes if they postponed seeking care or just didn't get care at all. And the orange bars are people without insurance. Okay, I don't know what happened. All right. So what I'm going to talk about today is the main things that the Affordable Care Act does. And it's a big law, and there's been lots and lots of press about how complicated it is. And I think it's a mistake to act like it's one thing. But broadly, what it tries to do is provide more access to care. And it does that in three ways: by expanding health coverage, by reforming private health insurance, and by undertaking a lot of other little things under the title of improving care and improving health. So, to expand access to care, like I just said, it expands coverage, and I'm going to talk about the ways that it does that. It reforms health insurance, and I'll talk about the ways that it does that. And it reforms this third category that's kind of a catch-all of a lot of things: reforming health delivery, promoting health through prevention, through public health, through demonstrations to test new models of healthcare delivery. And importantly, for people with disabilities, this is the category where new ways to deliver home and community-based services, this is where they fall under. For those of us in the disability community, we know that most people prefer to receive care or long-term services in a home or community-based setting. And the ACA undertook some reforms to try and expand access to those settings and make those settings a little better. But, okay, first of all, we'll start with expanding coverage. So, we expand coverage in two major ways. We expand Medicaid, putting more people under that Medicaid umbrella, and we also created health insurance marketplaces, places to shop for insurance. And at this point, I think most people are probably familiar with the marketplaces and what they do, but I'll explain a little bit. You might have heard healthcare exchange, you might have heard healthcare marketplace. They're the same thing. Exchange is the language that was actually in the law. Marketplace is what HHS started to call them because they found that that made a lot more sense to people than exchange. People didn't know what an exchange was. But it's intended to be a place where an individual or a small business can go to one place, usually through the internet, to figure out if they're eligible for private insurance, for subsidies, for Medicaid, or for the Children's Health Insurance Program. The plans on the marketplaces were each built into separate tiers called metal level, platinum, gold, silver, and bronze. And this was a way to try and help people understand health insurance. You know, there's been a lot of talk about how the ACA was really confusing. People are still having trouble figuring out their insurance, and one of the reasons is because we built it on an existing private health insurance system. Anyone if you ever tried to buy health insurance on your own pre-ACA, it was really confusing, really strange, really complicated, lots of words that kind of sound the same but don't really make sense. The ACA tried to make all of those complicated ideas a little simpler. Whether or not it succeeded is up for debate, but one of the ways that it did that was creating these metal level plans. So you have everything from a platinum plan, which is going to cost you a lot every month, but cost you very little if you actually get sick, all the way to a bronze plan, which will cost you very little each month, but a lot if you actually need the services, if you actually get sick. And then gold and silver kind of in the middle, trying to give people tiers to choose from. It also provided subsidies to help people afford health insurance. And it's based on your income as a percent of the federal poverty level, which I have in front of me the numbers for 2013, which still apply to the marketplace that we just ended, which was complicated. Anyway, in 2013, the federal poverty level for an individual was $11,490. So that's an annual income of about $11,500. So you take that level and say, okay, that's for one person. You know, for a family of 2, it's about $15,000. For a family of 4, it's about $23,000. So not a lot of money. You take that and they calculate a subsidy for you based on where you fit in relation to the federal poverty level. The subsidies expect that you will spend a little more of your income the higher your income is. So if you're at the lower end, you're only expected to spend about 2% of your income. At the higher end, about 9.5% of your income on subsidies. The way this is calculated is, like I said, they take the amount of your income that you're expected to spend on a subsidy, and then they give you a set amount, and then allow you to shop for a different plan. So I think that makes it a little easier to understand. Your subsidy doesn't depend on which plan you buy. You get a set subsidy, and then you can help figure out how much you can afford. All this is intended to go through an online portal. Anyone who has been paying attention in the last 6 months or so knows, more than 6, like 9, knows that the online portals did not work as well as we were hoping. Primarily, people just had a lot of trouble getting onto the website. It was a complex system that tried to link information from the Social Security Administration, Health and Human Services, the Internal Revenue Service, and state Medicaid. But in theory, the way that it's supposed to work is, like I said, you go to that one site and it tells you, okay, you're eligible for Medicaid or you're eligible for private insurance, either with or without subsidies. A common misconception is people talk about whether or not they're eligible for the marketplace. Anyone who wants to can buy insurance on the marketplace. Everyone is eligible. The question is whether you're eligible for those subsidies that come in the form of tax credits to assist in the purchasing of your insurance. And the fact that it's a tax credit, I think, is important to keep in mind. If you think about it in the most basic way, it's a tax credit for if you buy insurance. A lot of times people think about it like reducing the cost of the insurance, which is a good way to think about it. But another way to think about it is it's a tax benefit, just like lots of other tax benefits that you get for your home mortgage interest or paying off your student loans or lots of other things. It goes through a similar system. So you get your subsidy, you look at your plans, and you enrolled into a health plan. Another misconception, there's no like Obamacare card. A couple of months ago, a group tried to hold this event on the Hill where they were going to burn their Obamacare cards, but they had to print their own cards because there aren't Obamacare cards. If you receive subsidies to purchase private insurance through the exchange, you get that private insurance card, just like any other health insurance. So, as the law was originally written, they had the idea that each state would build its own exchange or marketplace. It was expected that all states would want to build their own marketplace because most states like to have the most control possible. That's not how it ended up working out. States officially have the option to either build their own marketplace, build a marketplace in partnership with the federal government, or if they do nothing, the federal government will build a marketplace for them. Those states that have the federally facilitated marketplace or the partnership marketplace both go through the infamous healthcare.gov. The dark blue states on your screen, they created their own state marketplaces. They have their own separate websites. So Michigan decided to create a partnership marketplace. And that means that Michigan and the federal government made an agreement where the federal government would do some things and the state would do others in partnership. But still, like I said, individuals experiencing the marketplace go through healthcare.gov, and for the most part, people on the ground aren't going to feel that much of a difference in a partnership to a federal marketplace. Consumer assisters still get federal grants. It's still, the marketplace is still run by the federal government. The state has some more back-end controls. I pulled some numbers for Michigan. Out of about 297,000 that were estimated to be eligible to enroll with financial assistance, about 272,000 enrolled as of April. So pretty good numbers in Michigan, getting most of the people who were eligible for financial assistance. So that's my talk about the marketplaces. Now I'm going to move on to the Medicaid expansion. As originally written, the Medicaid expansion was a requirement for all states. And what it was meant to do was, like I said, fill in the rest of the umbrella. Right now, children, people with disabilities, pregnant women, and some parents are covered depending on the state's different eligibility rules, which category you fall into. I'm sure those of you who work with people with disabilities have experienced this. If you're in the disability category or the parent category, it's different. Well, what this sought to do was said, okay, if you are an adult with income at or below 138% of the federal poverty level, you're covered. This helps explain some of what's changing and what's not. The disability categories still exist. The children categories still exist. All of that stayed the same, but they expanded it to say those other adults that weren't covered before, they are now covered, up to 138%. So if you've experienced, Medicaid eligibility for a person with a disability through the SSI system, all the same. It just expanded Medicaid eligibility to adults with lower income. However, say you have a disability but don't qualify through the SSI system or through the Medicaid disability system. If you're an adult and your income is lower than 138% of the federal poverty level, even if you have a disability, if you don't qualify through the original system, you can now qualify through this new system, the blue part of the slide. And that's kind of cool because we'll talk more about what those benefits are like, but it doesn't include an asset test, which I think is pretty exciting. We haven't seen that apply to too many people yet for a lot of reasons, but it's something important, I think, to keep in mind. Okay, so we just talked about how, as originally written, the Medicaid expansion was supposed to be required for all states. As I'm sure you know, there was a lot of partisan disagreement about the Affordable Care Act, and including a case that went all the way to the Supreme Court. And that case actually challenged a number of things, and everything in the law stood up except for the Medicaid expansion. The court said, no, if you're going to make changes to the Medicaid program, they have to be optional for states. States have to decide whether or not to opt in. This is how it's been for a lot of other changes in the Medicaid program in the past. So while from AUCD's perspective and a lot of other people who advocate for expanded health care, we wanted it to be required, the Supreme Court said, nope, it has to be optional. So here's a little graphic where I tried to explain the differences between how the law was originally written and how it works out now, and why that creates coverage gaps. So as originally written, if you had income up to 138% of the federal poverty level, including zero income, Medicaid would cover you. That's that top arrow that I put. If you had income between 100% and 400% of the federal poverty level, the marketplaces would cover you. So there's a nice actually overlap in between Medicaid and the marketplaces of people with lower moderate incomes could actually kind of choose between the two. That's interesting, that's cool. And it also explains why the marketplaces didn't go lower than 100%. When drafting the law, folks said, you know, if your income's lower than 100% of the federal poverty level, you probably can't afford private health insurance without any kind of subsidy. We would just have to pay for the whole thing. And if we're paying for the whole thing, well, we'll just give you Medicaid. That was how the law was originally conceived. After the Supreme Court, it changed. The marketplaces were still only available to people between 100 and 400% of the federal poverty level. But Medicaid became a lot more spotty. Because it was optional, it created what could potentially be a strange situation that's on the next slide, where someone could be that could have too much income to qualify for Medicaid, but not enough income to qualify for the marketplace. I personally, in my life, know people who have fallen into this category, particularly in states that have not expanded Medicaid, like Montana and Pennsylvania. This is something that happens. It's considered one of the big problems in ACA implementation right now. Is this gap? It seems pretty unfair, and it's something that I think a lot of people are trying to figure out how to correct. But if you're in a state that doesn't expand Medicaid, depending on your state's existing Medicaid eligibility, it could look like this. Of course, as you know, Medicaid is different in every state. So how big that red part of the umbrella is going to be depends on the state. The marketplace is the same in each one in terms of eligibility for subsidies, but Medicaid is different. So this is the current status of Medicaid expansion, including new states, just like Michigan, that have just entered the expansion. It's still, now there are more states expanding than not expanding. 27 states and the District of Columbia are expanding in some way, and 5 where there's still some debate going on. What's interesting is the number of states who have taken alternatives to the Medicaid expansion. I would say the most famous of these is Arkansas. Arkansas was the first one to come up with the idea of a private option Medicaid expansion, where they would expand Medicaid, but not actually give Medicaid services. They would use those Medicaid dollars to purchase private insurance for those who were eligible for the expansion. I gotta say again, this is just the expansion group. If you already were eligible for Medicaid before, it stays the same. But if you're eligible for Medicaid new, because of the expansion, you could get private insurance through the marketplace. It rocked the health policy world when this came out, and everyone was thinking, what are they going to do? But the federal government said okay. And then they said okay to Iowa for the same thing. A couple other states have gone through a waiver process where they apply and say, okay, we want to do Medicaid expansion, but we want to do it a little different. Michigan is one of those states, and I'll talk about that in a second. The other famous state doing it right now is Pennsylvania. Their application has not yet been approved because it's not private insurance, but it's Medicaid that looks like private insurance, is the best way I can describe it. In terms of cost sharing, that's co-pays, co-insurance, deductibles, that kind of thing. They want to put in a lot of those in the Medicaid program, and they want to have work requirements. Their proposal also gets rid of the Medicaid buy-in program, which you may be familiar with, but it's a way for people with disabilities who are working to maintain access to their Medicaid. This has been concerning to disability advocates, and so we've been weighing in Pennsylvania. But you guys are here to talk about Michigan, so we'll talk about Michigan. What it does is they have proposed, and it's been approved by CMS, to amend their existing Healthy Michigan plan. I'm sure some of you have experienced this. It would increase cost sharing for those new beneficiaries, so that's the new people in the expansion group. Not people on Medicaid before, but people new to Medicaid now. They would be enrolled in managed care plans and have what are called health savings accounts, or something like a health savings account, where you get a set amount of money to spend towards your healthcare services. Michigan has also been interesting in that they are going to compare their spending, and they have said that if they are not saving money on the Medicaid program by 2017, they will withdraw. The Medicaid expansion is primarily funded by the federal government, so most people are looking forward, and at least that I've read at the national level, saying Michigan will probably save money. I'd be curious if those of you on the state level are hearing anything else. And then the last thing that I think is exciting is that it does put an emphasis on preventive care and having access to primary care and preventive care. It also includes financial incentives for wellness activities. Wellness activities are great, like smoking cessation. Getting people to stop smoking, that's great. People are healthier, saves money. There's other wellness incentives that have been concerning to disability advocates because they might require a certain amount of physical activity or other activities that people are required to engage in that might not be good for a person with a disability. They might not be able to engage in the activity, and we want there to be a little more equity in the incentives. So my thoughts on the Medicaid expansion in Michigan overall is it's great that we're expanding Medicaid, but there's some things to keep track of in terms of what the cost sharing is like, what the wellness incentives are, how people are doing, and if Michigan plans to continue the program. Finally, the last part of expanding coverage is what we'll call individual and employer responsibility. And I put this in because it gets a lot of press. You might have heard it called the employer mandate or individual mandate. So I just wanted to be clear about what those things actually mean. So if an employer has more than 50 employees, they generally need to offer affordable coverage. And that means coverage that actually covers services and can't cost more than 9.5% of that employee's family income. If they don't do these things, and then one of their employees goes to the marketplace and qualifies for subsidies, that employer will have to pay a penalty. On the individual side, I will add, this employer mandate has been sort of delayed a couple of times. It's been tweaked. It still has not taken full effect, which has caused a little bit of political noise. But for the most part, most businesses with more than 50 employees already provide insurance, so it's actually a really small part of the market that is affected by this requirement. On the individual side, if a person does not have health insurance, if they qualify for their employer's insurance or marketplace subsidies and have turned them down, so this is like if your employer provides affordable coverage and you said no, or if you could buy a plan on the marketplace and you say no, And that marketplace plan would be no more than 8% of your income. And if you don't have an exemption related to religion or income or some other things, you might face a penalty. The reason that I put so many bullet points on there is because something that I think gets lost in a lot of media reports, there's a lot of ways out of this individual mandate, like affordability. If you fall into that Medicaid gap, where your state has not expanded Medicaid, you will not have an individual mandate payment. If you have a religious exemption, there's several different, I can't even list them all here, the ways that you can face some kind of hardship to not have to pay this penalty. It's mostly there, both of these here are not going to apply to that many people. They're mostly there to encourage people to get insurance. And the reason that it's called employer and individual responsibility as its official title is because it's based on the idea that we've done a lot of things to make insurance more broad. You coverage for pre-existing conditions and those kinds of things that I'm going to talk about in a little bit. But a way to kind of now it's people need to step up. You can't wait until. So the fear was that if you covered people with pre-existing conditions, people would wait to get insurance until they were sick. So this is a way to counteract that and a way to keep premiums from increasing. But like I said, it's not a lot of people. But I'll talk about this more again when I'm talking about how it applies to direct support professionals. Okay, this is the end of my coverage expansion section. I'm about to move on to the reform health insurance section, but I wanted to pause and see if anybody had any questions.
Hi, Rachel. We don't have any questions right now, but again, I sent a message out. If you have questions, please type them in the box and we'll address them as we go.
Okay, great. So now I'm going to move on to the second part of the presentation, which is about reforms to health insurance. And this is primarily the private health insurance market. Something that the policy wonks called the individual and small group market. And that means this is health insurance offered to individuals or to small businesses. A lot of big employers, universities, big companies actually have their own health insurance products, and so these don't apply. But this is most of the market for individuals and small businesses. So this is my slide with a bottle of champagne on it, because these are what we saw as the victories, particularly for people with disabilities. That a person, you can't be denied coverage because you have some kind of pre-existing condition. This is a huge, huge change for people with disabilities and a really, really big victory. That, along with the end of lifetime and annual limits. So as Mike said at the beginning, my sister has developmental disabilities. She also has a genetic condition that comes with a lot of really complicated medical issues. And when I was growing up, my mom had the same job for about 25 years, primarily because she was afraid to switch insurance companies. Yeah, Amy had Medicaid, but it really took a combination of Medicaid and private insurance to cover everything that she needed. Luckily for us, Amy didn't have any lifetime or annual limits, but that would have been terrifying. I can't even imagine if you have some kind of chronic health condition, or if your child does, being told, oh, you've reached your limit for your whole life. You're done. And you can't get more insurance because you have a pre-existing condition. So luckily those things have gone away, at least in the individual and small group market. They've also created what are called essential health benefits, and I'll explain that more in a little bit. And that is things that insurance kind of has to cover. And they're the things that we would think insurance generally should cover for the most part, but now insurance companies have to cover them. Other exciting things are a cap on out-of-pocket costs. increased access to preventive care, control on premiums, equity in premiums between men and women, a limit to how much they can vary between older people and younger people, and more coverage for young adults. If their parents have insurance, they can stay on that insurance. And these tend to be the most popular parts of the Affordable Care Act. People like this. This is good. So I'm going to talk a little bit more about those essential health benefits. There are 10 of them, and they include, a lot of things, like I said, that you would think would be covered. Emergency rooms, hospitalizations, maternity, lab services. The most important for people with disabilities are number 5, which is mental health, substance use disorders, behavioral health, that kind of thing. And number 7, which is rehabilitative and habilitative services and devices. And that's what I'm going to focus on most. So, rehabilitative and habilitative services and devices. What does that mean? And that is a really excellent question. And it's a question that people were asking themselves when they created the Affordable Care Act, saying, okay, we have to cover this. We know we say we have to cover this. What does that actually mean for a health plan in a state? So it's particularly problematic, and this goes to what's changing and what's not. Rehabilitation was usually covered by health insurance. Habilitation was not. So how are those things different? Rehabilitation is helping you regain a skill or ability that you had but then lost due to illness or injury. If you were in an accident and had a physical injury and needed physical therapy, maybe you needed a wheelchair or crutches, that's all rehabilitation. Habilitation, without the re, is helping a person gain skills or abilities or knowledge that they didn't have before. So you can imagine this is most applicable to people with developmental disabilities. This is someone who never learned to speak, needing to learn to speak or communicate in some other way with a speech pathologist. That's a habilitation. There can also be physical therapy for habilitation for people who need to learn to walk or otherwise have mobility. Okay, so we've got rehabilitation and habilitation. Rehabilitation has usually been covered. Habilitation has usually not been covered. What is that going to mean for the essential health benefits? Well, the way that all of the essential health benefits are figured out is each state picks what's called a benchmark plan. The Department of Health and Human Services said, okay, in each state we have these essential health benefits. They have to be covered. Let's say that they have to be covered kind of like how they're covered by other plans in that state. So by state government plans or federal government plans or some other large employer plans. Pick that as your benchmark, and that's kind of what your benefits should be like. Okay, so 1, you pick your benchmark plan. 2, okay, does it cover your essential health benefits? 3, if it doesn't cover those benefits, you gotta come up with a definition. You gotta say what that means. Habilitation, not usually covered. So almost all states have to go through a process of figuring out, okay, what are we gonna have for habilitation? Either the state can define it, the plan can provide it with what's called parity with rehabilitation, which means they can take their rehabilitation benefit and say, habilitation, you get the same stuff. Or they can determine their own set of services and report these to HHS. This is a unique process just for habilitation, and it's going to apply almost exclusively to people with developmental disabilities. So that's why we spend so much time on it. Like I said, the state can come up with a definition, they can provide it like rehab, or they can come up with their own set of services. So, what do they do in Michigan? Michigan chose a private provider as their benchmark plan, the Priority Health HMO. I'm not from Michigan. I don't know if any of you have that, but that's what was chosen as the benchmark. That means that most providers are going to have to follow similar to what they provide. Interesting, in Michigan, applied behavior analysis, which falls under this benefit, was already required by the insurance commissioner, so that has to be included in all of the health plans. They also included 30 visits to a physical therapist or occupational therapist or a chiropractor, so that's 30 visits total for those settings. 30 visits of speech to a speech pathologist, and 30 minutes of cardiac or pulmonary rehab. So they made their HAB and their rehab benefit kind of the same. Compared to some of the other plans that we have been looking at the national level, it's pretty good. It's not bad. I'm sure some other folks who may be experiencing this plan right now have thoughts on whether or not it's good or bad, but compared nationally, this is just basically, I don't have data on this, but this is sort of my take comparing it to others. Other states are much more stingy, so that's pretty good. Okay, that is the end of my section on reforming health insurance. It's pretty straightforward. I mostly focused on those insurance reforms and then drill down pretty quickly into the habilitation benefit. So I don't see any other questions. So I'm going to go ahead.
We do have one question, Rachel.
Oh, great.
Yeah, we have one question from Laura. She said, just wondering, and hopefully you didn't already talk about it, she had audio problems, if Rachel could touch on Medicaid deductible and how to help those individuals keep their coverage. We especially see problems when there is dual eligibility with the Medicaid, Medicare.
I guess I'm not sure what you mean by Medicaid deductible, unless Medicaid in Michigan has a... So not all Medicaid programs would have a deductible, although I'm maybe thinking that Medicaid in Michigan does. So I'm going to talk more about Michigan's efforts to integrate care for people with Medicare and Medicaid, and hopefully I talk about it, but if I don't, ask me again. Okay. So in section 3, we're going to talk about reforms to health delivery and health promotion. Like I said, this is the big category of like all the other things that the ACA does. Most news coverage seems to focus on numbers 1 and 2, the expansion of coverage, the marketplaces, Medicaid, that individual mandate, and changes to health insurance like pre-existing conditions, premium control, stuff like that. But I'm sure you've all heard reports about how this law was like hundreds of pages long. There's lots of other stuff in there, and a lot of it's pretty small, but together it's meant to change our health system overall. So I'm going to touch on some things that are important to people with disabilities. So it included demonstrations to integrate care for people with Medicare and Medicaid. It included standards on accessible equipment and diagnostic equipment specifically for medical offices, training for providers on how to interact with people with disabilities, and home and community-based services. So first, these state demonstrations to integrate care and align financing and/or administration for dual eligible beneficiaries. It's a mouthful. We usually just call it the duals demos for short, but what they're trying to do is tackle a problem that I'm sure you all know exists, which is if you are eligible for both Medicare and Medicaid, it's kind of a mess. Your care can be confusing, it's hard to see what's covered, you can bounce between one program and the other, going through an appeals process, you're trying to integrate lots of different payers with lots of different services, and the person who has both Medicare and Medicaid probably has some really complex conditions and not a lot of money. So, knowing that this was a problem, the law created what are called demonstrations, where they're going to fund some states to do an experiment. Say, okay, we're going to do a couple of different things. to try out and figure out what the best way is to help these people have better integrated care, better financing, just a better system overall. It also helps the administration of the system. One, smoother administration will help beneficiaries, and two, the administration of these things is a huge headache for states. So if they could spend less time and money trying to figure this out, that would be good too. On this map, they show where people are in the process. There's been a lot of states doing a lot of different things. That's why there's so many different colors. But the orange states have either started or are about to start. That means they submitted it to the federal government, the government approved it, and they have signed an MOU, a Memorandum of Understanding. Some other states are doing some other thing, but the orange states are the ones sort of doing the full demonstration. Michigan is one of those states. So they're doing what's called a capitated model. My health policy professor used to make fun of the word capitated because he thought it sounded like decapitated, but really it just means per person. The state and the federal government sign a contract with a managed care organization, and they give that organization a set amount of money for each person who's enrolled in Medicare and Medicaid. Those of you in Michigan, I think, are probably pretty already familiar with Medicaid managed care. You've had it for a little while. And this system attempts to build on top of your existing Medicaid managed care system and integrate Medicare as well. So they built upon the prepaid inpatient health plans, which I understand to be your existing Medicaid managed care system, and created new integrated care organizations. So the prepaid inpatient health plans will cover behavioral health, developmental disability services, substance use disorders, service coordination, and other outpatient supports. The integrated care organizations will cover physical health, so that's acute care, primary care, going to the doctor, going to the hospital, those physical needs, pharmacy, and long-term services and supports. And I'll admit, when I was reading this, I was kind of surprised to see in a demonstration that's meant to be integrating things, creating two separate integrated organizations. I didn't really get it, but the contract says that the PIHPs and the ICOs must work together, they must share an electronic platform, they must coordinate care, and from what I understand, a beneficiary should see one system, one integrated system, even if the back end has multiple organizations. Michigan will have what's called a passive enrollment with opt-out, which means they will contact the people they're looking to enroll and say, you're going to be enrolled. Tell us if you don't want to. That process is going to start in July of 2014, at least according to the documents, but it will be phased in. It should not be everyone on Medicare and Medicaid, but a group of people. It's going to start with people who don't use long-term services and supports, then move on to people who are residing in nursing homes or receiving waiver services. So those are probably going to be people with disabilities, except last, it's going to be people with intellectual and developmental disabilities. I couldn't yet find in the documents when each of these phases is going to start, but that's something to pay attention to from an advocacy standpoint. I know it's going to start in July 2014. Some states have moved pretty quickly on these things, so good to stay on top of. This is where someone asked a question about Medicaid deductibles. Did they have a chance to explain a little more what they were specifically asking?
No, they did not.
Okay. All right. Well, I'll keep going. I don't think I covered that. I'm not, have to admit, 100% sure what you mean. So if you could explain a little more, I will get back to it. So the next delivery reform that are exciting for people with disabilities are requirements around accessibility of medical diagnostic equipment. If any of you have ever worked in health and disability, or even just tried to, if you yourself have a disability or went with someone with a disability to the doctor, it's amazing how our offices are not accessible yet. We like to remind people that the ADA was passed in 1990. Unfortunately, a lot of things aren't accessible yet. So what they said is that the Access Board, which is the federal government interagency sort of collaboration, should create standards for accessible medical equipment, particularly diagnostic equipment. The Access Board, the Food and Drug Administration, and the Department of Justice Disability Rights Section are working on that right now. They came out with proposed rules in February of 2012 and an advisory report published in December of 2013. We have not seen any final rules yet on those standards, and there's still a question about the extent to which they will be enforceable, but we are still paying attention and seeing this as a step forward toward greater accessibility in medical equipment. Oh, and I should mention that the ADA, it technically already covers equipment, but the new standards are intended to provide clarity, and complaints can be brought against those standards, and it will help complaints to be brought. So it's kind of complicated. The ADA applies. This is supposed to make it a little more applicable. Third exciting thing is there's supposed to be funding for doctors and other providers to be trained on cultural competence, but part of that is training on interacting with people with disabilities. This is a significant issue that I know a lot of people face. For some reason, particularly dentists, it's really hard to find a dentist who will serve someone with a developmental disability. Maybe they feel like they don't know how to do it, or something like that. The ACA included grants to medical schools and other training specifically on interacting with people with disabilities. Unfortunately, even though it was authorized in the Affordable Care Act, it has never been funded by Congress. This is something we would very much like to see funded, particularly at AUCD. A lot of our members do this training, exactly, and we think that they could do a really, really great job increasing the number of providers who can interact with people with disabilities in a positive way and feel confident that they know what they're doing. So I always tell people, if you're looking for something to advocate for, tell Congress to fund this provider training on disability. Finally, I will explain a little bit about the new home and community-based services incentives in the Affordable Care Act. So to start with, Money Follows the Person was money designed specifically to help people transition from some kind of facility, be it an intermediate care facility or a nursing home, into the community. The ways that it did that was providing a little extra federal financial participation for the states and allowing states to spend money on things Medicaid usually doesn't cover. Startup costs for people who are getting an apartment, maybe a deposit, maybe the stuff they need for the apartment to have pots and pans and beddings and things. You could spend the money on this. It was originally created in 2006, but it was expanded and continued in the Affordable Care Act. And now I think something like 46 states are participating, almost all of them. New in the Affordable Care Act, yes, is the Balancing Incentives Program, which is pretty exciting because depending on how much states currently spend on home and community-based services, they can get increased federal money to provide more HCBS. So most states fall into the category if they spent between 25 and 50% of their long-term services dollars on the community, they can get a 2% match So that's basically for all the Medicaid dollars they spend, they can get 2% more on LTSS if they implement some pretty cool things like a no wrong door policy, increased case management, a standardized assessment. It's a really, really great program because it's almost like free money for the states. They have to follow certain standards, like I said, about a no wrong door policy, but they can get increased money to help them transition their system to home and community-based services. States can apply through September of 2015. Michigan is not currently participating. I actually put a star on Money Follows the Person because that's the only one that Michigan is currently participating in. Third is the Community First Choice option, also known as 1915K. Some of you may have seen there's 1915C waivers. It's all the same part of the big Medicaid law. This part is called 1915K. It is also a very exciting part of the Affordable Care Act that provides, if a state chooses this option, they can get 6% more money from the federal government to provide home and community-based services without a waiting list. It has to be for people who qualify for that institutional level of care, but the lack of waiting list is really, really exciting. It's a big undertaking, which is why only 2 states so far have fully implemented it, and that's Oregon and California. But we're hoping to increase that number a lot. Finally, the Affordable Care Act also expanded what's called state plan home and community-based services option. It doesn't have as good of a name as Community First Choice, but it's through 1915I, and that was the first time that a state could provide home and community-based services without a waiver. It's another good option. A lot of states are using it in the mental health arena. This next slide shows who is participating in what. So you can see Money Follows the Person is first at 46. We've got about 18 in that balancing incentive program, about 14 in the state plan option, 1915I. And this shows 10 in Community First Choice. I think that's showing the number who say they have either started it or applied or plan to apply. So only 2 states are actually really doing it right now. So I've reached my recap of what we talked about. So, the question was, what does this mean for people with disabilities? And so, we talked about all of the things. We talked about expansions of coverage. We talked about reforms to insurance. And we talked about reforms to the health system overall. In a nutshell, there's a couple big changes. The new integrated care for people who are dually eligible for Medicare and Medicaid, those duals demos that I talked about, have the potential to really change how services are provided for people with disabilities. It is a managed care system, so that is both exciting and can be scary depending on how it's implemented. I think it's a great place to pay attention to what your state is doing, how the services are working out for people, because in the states where it's successful, it has the potential to be implemented across the whole country. There are several groups paying a lot of attention to this, including one whose website is called dualsdemoadvocacy.org. I can type that out later. But it's a bit of a longer term thing, but as you guys know, the services for people who are dually eligible are a big problem, and we're currently testing models to figure out which one we want to make happen in the whole country. Second is the expansion of Medicaid, including the potential to access Medicaid without an asset test. I think that's really exciting. It's a new avenue for Medicaid access. And finally, the habilitation, rehabilitation in private health insurance, something that hasn't been provided before. Before, you had to go to Medicaid to get habilitation, and that's changing. You can get access to those services in your regular private insurance. And finally, I always give a point of advocacy. a great place for advocacy in Michigan would be those home and community-based services that I listed, primarily the balancing incentive program and the community first choice option. I encourage you to take a look at that, especially balancing incentives. It's like good money for states, and it allows states to do really cool things because it provides flexibility with the funding. Finally, what does it mean for direct support professionals? So I'm going to bring up those duals demos again, but from a slightly different angle. This has the potential to change how long-term services and supports are provided and paid for. Your agency that you work for, or you as an individual, could soon be interacting much more with a managed care organization. You could be expected to participate in care integration activities, maybe helping people make it to new assessments, helping people manage, working with care coordinators. Depending on how it's done, you could be part of a care team. And the way that you and your organization are paid might change. You as an individual can have better access to healthcare through Medicaid and the marketplace, especially in Michigan now that they are expanding Medicaid. We know that being a direct support professional is not a very well-paid job, so a lot of folks might land in that Medicaid expansion area or to receive subsidies in the marketplace. And finally, I know a lot of agencies that employ direct support professionals and agencies that provide long-term services are having the pay or play question. That's what I talked about before in the employer mandate section. Like we said, organizations with more than 50 employees, with some exceptions, have to provide health insurance. So there's agencies that previously did not provide health insurance, and so they have to figure out how that mandate applies to them, and they might be providing it in the future. Finally, I wanted to remind you about healthcare.gov. It's not over. Open enrollment in the health insurance marketplaces ended at the end of March, but there's a whole other thing that I didn't even talk about called a special enrollment period. People can qualify for Medicaid all year long, and if you've had some kind of change in life, a different event, you moved, you had a kid, you got married, there's tons of them, you can qualify for what's called a special enrollment period and go into the marketplace and select a plan as if it were during open enrollment. Open enrollment is over, so I took out my open enrollment slide, but I realized I should have talked about that. That was between October and March of this year. It'll start again next year. I think in November it'll be a little shorter. But this is a way you can still go to healthcare.gov and figure out if you still need health insurance. You can figure out if you still go to the marketplace right now, even though open enrollment is not open. So that is what I have for my presentation. I'm now ready for any questions. That's my little picture of a person who's still confused. So please, let me know if you have any questions. We have plenty of time.
We do have a couple questions, Rachel.
Great.
Okay. The first, Laura's clarified her previous question. Quote, if a person has just a little too much income but would otherwise be eligible for Medicaid, especially those with disabilities, they are put on a spend down and have to spend extra income on health care services in order to be eligible for Medicaid services every month. I'm not sure if any other states do this, but so far the ACA has made this group put this group into a bind rather, because they cannot buy into the marketplace because of the Medicare, and are putting a huge burden on the PIHPs because the state cut almost all of the general fund with the idea that general fund was no longer needed since everyone will be covered, quote, in quotations. It's a really tough spot for these folks who are now losing services because they can't afford their health care and neither can their PIHP.
Oh, interesting. Okay, that helps a lot. So Medicaid spend down is something that happens in every state, but it happens differently in every state. just because different states have different rules about how much money you have to spend, what you can spend it on, how far the look back is for what you spent that money on. The intersection of the ACA and the Medicaid spend down is not something I'd actually thought about before, realizing that if you have Medicare, you're eligible for the marketplace, but if you're trying to access long-term services, you want to be eligible through the Medicaid expansion. Unfortunately, I don't have, an answer to how the ACA, how that was planned to be addressed. It seems like maybe your state took some actions that exacerbated it. I wish I had a better answer for you. Other than that, that is something that happens in every state. And that's something good for me to look into to figure out if other states are having the same problem.
We have another question from Mary. She asks, is there a benefit for opting into integrated care?
That's a really good question. And I didn't see in Michigan's explanation any kind of financial benefit, but I think it would be really good if you could, if you or one of your loved ones is contacted saying, we want to enroll you in this plan, really researching your options, researching what it's going to be like. And I know that's going to be hard. It's really complicated. But unfortunately, I can't answer your question other than say it's going to depend. I don't think there's, any direct financial benefit. What I think there is looking at how they plan to organize services, what networks they plan. Can you keep providers that you like? Could you maybe access new providers that you didn't have access to before but would like? It's going to take research on your part to figure out what services they are and how they plan to provide them.
And just to answer another Mary's question, yes, the webinar is being recorded, and I will send a link to the archived webinar that will be up for a short period if you wish to watch it again. And going back to the original question, just scroll up here, about integrated care. Mary asks again, do you mean in-home providers?
I don't know for which. In the network? Yeah, possibly. So it is going to be delivered through a managed care entity. This is for the duals demo in Medicaid. So, when we're talking about providers, I would look at physicians, therapists, in-home providers, anything that individual person currently accesses or would like to access, and see what they have in their network.
We'll just give people a second if there's any more questions before we sign off. Okay, I don't see any more questions right now, Rachel, so thank you so much for joining us today and providing this wealth of information. And for the folks that have joined us today, there will be a link sent out to everyone who attended, or everyone who registered for the webinar originally, that we will have it archived for a couple weeks for those who wish to either watch it again, just to clarify points they may have missed. And if you have any questions after today, you can feel free to email myself at ddi@wayne.edu. We can pass questions on to Rachel. And once again, thank you so much. Rachel, you're getting a lot of kudos in the question area here as well, just to let you know.
Oh, great. Thank you.
And thank you once again. Everybody have a great Thursday.